Medical anthropology studies human health and disease, healthcare systems, and biocultural adaptation. It views humans from multidimensional and ecological perspectives. It is one of the most highly developed areas of anthropology and applied anthropology, and is a subfield of social and cultural anthropology that examines the ways in which culture and society are organized around or influenced by issues of health, healthcare and related issues. The term medical anthropology has been used since 1963 as a label for empirical research and theoretical production by anthropologists into the social processes and cultural representations of health, illness and the nursing/care practices associated with these. Furthermore, in Europe the terms anthropology of medicine, anthropology of health and anthropology of illness have also been used, and medical anthropology was also a translation of the 19th century Dutch term medische anthropology. This term was chosen by some authors during the 1940s to refer to philosophical studies on health and illness. In the United States, Canada, Mexico and Brazil, collaboration between anthropology and medicine was initially concerned with implementing community health programs among ethnic and cultural minorities and with the qualitative and ethnographic evaluation of health institutions, hospitals and mental hospitals, and primary care services. Regarding the community health programs, the intention was to resolve the problems of establishing these services for a complex mosaic of ethnic groups. The ethnographic evaluation involved analyzing the interclass conflicts within the institutions which had an undesirable effect on their administrative reorganization and their institutional objectives, particularly those conflicts among the doctors, nurses, auxiliary staff and administrative staff. The ethnographic reports show that interclass crises directly affected therapeutic criteria and care of the ill. They also contributed new methodological criteria for evaluating the new institutions resulting from the reforms as well as experimental care techniques such as therapeutic communities. The ethnographic evidence supported the criticisms of the institutional custodialism and contributed decisively to policies of deinstitutionalizing psychiatric and social care in general and led to in some countries such as Italy, a rethink of the guidelines on education and promoting health. The empirical answers to these questions led to the anthropologists being involved in many areas. These include developing international and community health programs in developing countries, evaluating the influence of social and cultural variables and the epidemiology of certain forms of psychiatric pathology, transcultural psychiatry, studying cultural resistance to innovation in therapeutic and care practices, analyzing healing practices toward immigrants, and studying traditional healers, folk healers and empirical midwives who may be reinvented as health workers, the so-called barefoot doctors. Also, since the 1960s, biomedicine in developed countries has been faced by a series of problems which demand that we inspect the, unfortunately named, predisposing social or cultural factors, which have been reduced to mere variables in quantitative protocols and subordinated to causal biological or genetic interpretations. Among these the following are of particular note. A. The transition between a dominant system designed for acute infectious pathology to a system designed for chronic degenerative pathology without any specific etiological therapy. B. The emergence of the need to develop long-term treatment mechanisms and strategies, as opposed to incisive therapeutic treatments. C. The influence of concepts such as quality of life in relation to classic biomedical therapeutic criteria. Added to these are the problems associated with implementing community health mechanisms. These problems are perceived initially as tools for fighting against unequal access to health services. However, once a comprehensive service is available to the public, new problems emerge from ethnic, cultural or religious differences, or from differences between age groups, genders or social classes. If implementing community care mechanisms gives rise to one set of problems, then a whole new set of problems also arises when these same mechanisms are dismantled and the responsibilities which they once assumed are placed back on the shoulders of individual members of society. In all these fields, Local and qualitative ethnographic research is indispensable for understanding the way patients and their social networks incorporate knowledge on health and illness when their experience is nuanced by complex cultural influences. These influences result from the nature of social relations in advanced societies and from the influence of social communication media, especially audiovisual media and advertising. Currently, research in medical anthropology is one of the main growth areas in the field of anthropology as a whole, and important processes of internal specialization are taking place. For this reason, any agenda is always debatable. In general, we may consider the following 6 basic fields: the development of systems of medical knowledge and medical care, the patient-physician relationship, the integration of alternative medical systems in culturally diverse environments, the interaction of social, environmental and biological factors which influence health and illness both in the individual and the community as a whole, the critical analysis of interaction between psychiatric services and migrant populations, critical ethnopsychiatry, Ben Duce 2004, 2007, the impact of biomedicine and biomedical technologies in non-Western settings. Other subjects that have become central to the medical anthropology worldwide are violence and social suffering, as well as other issues that involve physical and psychological harm and suffering that are not a result of illness. On the other hand, there are fields that intersect with medical anthropology in terms of research methodology and theoretical production, such as cultural psychiatry and transcultural psychiatry or ethnopsychiatry.